So let me introduce myself, everyone. I'm Shalaka. I live in Bombay, and most of you all know me. But there are many faces here from the ILD communities here, especially who may have only heard of me, maybe, or maybe do not know me at all. I also live with pulmonary hypertension myself, and I represent Pulmonary Hypertension India along with my co-host here, Dr. Prachita Shah. We both are patients of pulmonary hypertension. Prachita lives with idiopathic pulmonary hypertension, and I live with PH secondary to an atrial septal defect, which is a congenital heart defect. I was also recently diagnosed with pulmonary veno-occlusive disease, which is another group 1 pulmonary hypertension. Let me speak very briefly about Pulmonary Hypertension India. We are a patient support and educational platform created exclusively for pulmonary hypertension patients, and we are run exclusively by pulmonary hypertension patients. At PHI, we are all patients undestroyed and undefeated in a way. Our mission is simple. We want to empower, educate, and enable Indian pulmonary hypertension patients to make good decisions and the right choices in dealing with this life-changing condition. We do this by making knowledge, access, and community our primary goals. Today, we are going to speak about palliative care, specifically in the context of its usefulness for people living with chronic lung diseases such as pulmonary hypertension and interstitial lung diseases. These are two very difficult and often debilitating conditions that have a systemic impact on the human body. These are both progressive conditions that are known to shorten lifespan. Our cardiologists and our pulmonologists are experts at slowing down the progression of these diseases, but there are other aspects of living with these conditions that are often ignored or completely forgotten. These are the emotional, psychological, social, financial, and caregiving aspects that have an equally big impact on our lives as patients. When these are managed well, these are softer aspects of managing a disease, and when they are managed well, they can actually enhance a lifespan and a well-being. They can add meaning, self-respect, and dignity to a life otherwise marred by excruciating symptoms and the prospect of early death. Palliative care is an all-encompassing term here and a medical subspecialty that provides specialized care to individuals with serious illnesses. The primary focus here is always on providing symptom relief, pain management, and relief from psychosocial distress, regardless of diagnosis or prognosis. It aims to improve the health-related quality of life for patients and families and can be provided in concert with pharmacological treatments. To speak on the subject today, we have one of India's most well-loved and very well-respected interventional pulmonologist and palliative care medicine specialist, Dr. Rajani Surendar Bhat. I'll give a very brief introduction to Dr. Bhat right now. Dr. Rajani Surendar Bhat is an accomplished interventional pulmonologist and a palliative medicine physician. She completed her postgraduate education in the United States and has been practicing in Bangalore at Sparsh Hospital since 2010. Dr. Rajani is actually a graduate from Lokmanya Tilak Medical College, University of Mumbai. She also trained at Tata Memorial Hospital and Research Center, and she went on to pursue her further studies with a residency in internal medicine at Lincoln Medical and Mental Health Center, New York. She subsequently finished a dual fellowship in pulmonary disease and critical care medicine at Montefiore Medical Center, Albert Einstein College of Medicine in New York. Dr. Rajani Bhat has completed the National Fellowship in Palliative Medicine from the Institute of Palliative Medicine at Calicut. She's also currently pursuing an advanced certification in neuropalliative care from Kasturba Medical College in Bangalore. Dr. Rajani Bhat is actually one of a handful of physicians in India whose scope of practice ranges from specialty clinics in outpatient medicine to interventional procedures in critically ill patients. She also deals with palliative medicine and end-of-life care. It happens to be one of her passions. She has been a consultant at leading hospitals in Bangalore in state-of-the-art interventional pulmonology departments. She brings a patient and family-centric evidence-based approach to her clinical practice. She's also published in various international journals, medical journals. She has contributed as co-author to national medical guideline statements in pulmonology as well as palliative medicine. She has a deep interest in public health and volunteers a spare time with non-profit organizations in the healthcare sector. Dr. Rajani Bhat, thank you so much for being here today. And I will open the floor to you now. Please tell us a little about palliative care in pulmonary hypertension and interstitial lung disease. Welcome.
Thank you for inviting me, Shalaka. So I'll start with just a brief introduction about how I got involved in palliative medicine for chronic respiratory diseases. And I did my training, as you mentioned, in internal medicine, and then followed that up with pulmonary disease and critical care medicine, and then interventional pulmonology. And as a young idealistic doctor in training, you sort of think that the best of medical treatment will really help your patients get better. And then as you start learning more and doing more and growing in your practice and in your journey as a doctor, you realize that there are some conditions for which, despite the best available medical innovations, the best available science coming up with newer medications, our patients still are left with a great amount of distress in their lives. And maybe we haven't been trained enough adequately to address it. And that's where I found that my training really was inadequate. And in as much as you start experiencing a sense of helplessness and you feel like I'm not able to do enough for my patients. And that's around the time that I developed an interest in studying breathlessness more and studying palliative medicine more, and realized that there's plenty more in terms of medical science that this field has to offer. And if one took a more integrated approach, where you say that any patient with any complex illness, where there's a set of symptoms, it's not just a straightforward one medication, one disease, one medication, one set of problems, but here you have intersecting organ systems which are coming into play, and it really affects your day-to-day life over a long period of time. These are areas where palliative medicine has a role to play. In the past, palliative medicine was always thought to be something which was for cancer, which was for chronic pain. But in the last decade and more, in the last 2 decades almost, we've realized that as we're all living longer, we're living longer with illness, and therefore we're also living longer with some distress. And this field has helped a lot in helping us to alleviate that distress. We've learned a lot more about how pain affects our mind and body. We've learned a lot about how breathlessness affects our mind and body, and how each of these has an impact on disease progression, on quality of life, on outcomes of patients. So that's sort of where the work in chronic breathlessness comes from. There's been a huge advance in the field of breathlessness research, and just as much of work was done on pain is now done on breathlessness, and we are now recognizing the neural pathways in the brain and the systems about how breathlessness impacts our life, and actually able to figure out interventions which we can offer our patients, more than just a prescription of a diuretic or oxygen or a bronchodilator or steroid, whatever be that. So there's studies now which tell us that if you have an integrated palliative medicine approach for people who have chronic respiratory conditions, who might require oxygen, and this is for a gamut of all the respiratory conditions, it's not just that the quality of life improves, but it's actually a survival benefit. And that's powerful, isn't it? That's the gold standard, that you live longer with a better quality of life. And that's why I think it's a really important field for more and more people to enter into. And it's also something that as a patient community, one should feel empowered and ask for it as well, that I need more than just medication. I need a support system here. And I think what you've done with PH India, just as we spoke a little earlier, having a patient support community is a strong part of palliative medicine as well.
Okay. Doctor, we have a few questions for you, and should we just do this as a Q&A right now?
Absolutely.
Some of these are questions related to patients' everyday lives and real world experiences. I think this is going to be a very useful Q&A for everyone who's joined us today. Doctor, so the very basic first thing is why palliative care for pulmonary hypertension patients and interstitial lung disease patients?
So palliative medicine is meant for anyone who has a chronic life-limiting illness, as you mentioned, and which affects their quality of life. Where with palliative medicine, you also mentioned that we focus on symptoms. Now, this is where, when you go to a specialist doctor's office, very often they're looking at your CT scans, your echocardiogram reports, your blood tests, your 6-minute walk distance, your oxygen requirement, your weight, your vitals. And sometimes the answer to questions about how you're feeling is, I'm still breathless. Now, how do we quantify that? And what does that translate into in terms of how is this affecting my life? So, okay, I might be breathless, but is it impacting my life in a way that I'm still able to carry on my usual activities, my professional responsibilities, my personal responsibilities at home, or is it limiting me in some way? The measures that we've had so far have been very, very broad, I think. And now palliative medicine is one of those areas where we're starting to define it better, so we can fine tune and titrate and find ways of using non-pharmacological as well as pharmacological means in order to relieve that symptom burden which is there. Because we know that chronic breathlessness, just like chronic pain, actually shifts our brain chemistry and the way we think, the way we move, all of that, right? So we're trying to even offset the future effects of what breathlessness is doing to us today. So that's why I think the integration of palliative medicine for chronic respiratory disease like interstitial lung disease or people with pulmonary hypertension becomes very important when it starts affecting their everyday life and limiting what they are able to do with it.
All right. Okay. And so this is not a one person job, right? It's not a one person. Like even as a doctor, you will have to work with a team of experts, right?
So as there's two aspects to palliative medicine. One part of it is primary palliative care, which all your doctors should be able to provide to you, which is just simple management of symptoms. If it is one or two symptoms, and titration of teaching you a few simple non-pharmacological techniques, teaching one how to manage diet and exercise, and rehab, all of that could help you. It's when the symptom complex becomes more, when you have multiple organ systems getting involved and multiple symptoms coming in, that someone has pain, they have sleeplessness, they have anxiety and depression, along with their breathlessness, along with palpitations, along with constipation, along with nausea, or diarrhea, along with nausea. There's a lot that's going on, and very often just shifts about managing the disease. So it becomes what is the matter with the patient, not what matters to the patient, right? Now, it
Very
might
important.
be
Yes.
that you might have a bunch of symptoms, but there might be one thing that is more important to you from a quality of life perspective. Now, a palliative medicine hat, when I'm wearing my palliative medicine hat, I'm really saying I'm ready to let go of a few other clinical goals in order to achieve what is important for you for your quality of life. When it becomes many, many complicated, intertwined symptoms and medications, then you need a specialist palliative medicine doctor to come in. And that's also when you might need the team to come in with a clinical psychologist, with an occupational therapist, a nutritionist, a physiotherapist. So all of this then becomes part of this support, palliative care support community. It's always a multidisciplinary team. That is specialist palliative care. Primary palliative care is what your regular doctor can offer.
You mean to see a PH specialist or an ILD specialist to be able to offer some palliative care services?
The basic palliative care services should be possible by all doctors. It's when things get a little more complex, then you definitely should be requesting for or asking for special services. And that's probably when you have a decline in your clinical condition or an increase in your symptoms or more hospitalization. So any of these things can trigger saying that, I think I need a little more help than just medicine.
Okay. So at what point should patients ask for these, and who should they ask for? Should they ask about it to the cardiologist or the pulmonologist? And when? Like at the time of diagnosis, later?
So we usually say that introducing the palliative medicine consultant as part of the team that's taking care of you is best early on. So, it's palliative care and curative medications go hand in hand. It's about which one is taking more space in your daily routine, right?
Okay.
If the symptoms are a lot, then the focus is palliative at that point. When the symptoms come down, then we go more stronger into curative treatment and building up strength and things like that. In terms of when do we ask, when is a good time to ask for palliative medicine? I think usually it's important to involve palliative medicine if you've had repeated hospitalizations or you see a decline that's coming in that's very measurable, like a really, not able to walk a certain distance, or a requirement for oxygen coming on for the first time, or an increase in the requirement for oxygen. So when you have certain shifts that are going to affect your life and your family's life, that might be a time to involve palliative meds. But I wouldn't leave it until critical illness and a prolonged hospitalization. Let me put it like.
Okay, got it. So you spoke a lot about breathlessness research and the new aspects of breathlessness care that are coming into play. Please, could you speak about it a bit? Because I think this is something that all of us, whether ILD or PH, we suffer a lot very often through the day. How do we manage that?
So one of the important aspects of breathlessness that we've learned about through, and this is all through, pure science, applying the same principles that we did in looking at pain research about which areas of your brain are involved when you're feeling breathless. What are the kind of signals that your body is receiving, and what is our response to those signals? Some very simple interventions have come about, and that is, first and foremost, while you are well, learning good breathing techniques. So there's three aspects that we look at: breathing, thinking, and functioning. So very often what happens is that when you have breathlessness for a long period of time because of a medical condition, you start breathing in a way that may or may not be useful to you. So it's a maladaptive response. Your breathing technique may not be right. And so learning the right way to breathe, learning how to be aware of your breath and to be able to regulate it. That becomes an important part. So breathing, pursed lip breathing, blow as you go breathing, breathe in a rectangle, keeping your hand on your chest and on your belly and being aware of abdominal breathing, belly breathing like a baby. Learning in terms of thinking, what happens to me when I feel breathless? What are the thoughts that come into my mind when I'm breathless? Is there a rising anxiety? Is there a panic? Am I worried about something? Is it making me block out all other inputs from other people who are trying to help me? So just learning to recognize that I'm going into a thought cycle that may not be useful to me and that may be worsening my breathing. So that becomes another aspect of it. And functioning, what happens when one gets breathless? One moves less. And if we move less, our muscles get weaker. And then that's a vicious cycle. My muscles are weaker, I'm more breathless, I'm more scared, I move less. And that's basically the cycle that we're trying to break. So it's about learning to live with breathlessness. We accept breathlessness and say, this much I can manage, but I will keep moving. And to learn to recognize your own body's signals would say that, oh, it's a little more than that, to learn to monitor it. So just like a diabetic patient would monitor their sugars, this becomes something that I am able to rate my breathlessness and say, oh, I am breathless when I go to the bathroom, or, oh, I am breathless when I sit up and get out of bed. Oh, I'm breathless when I climb one flight of stairs. So being able to recognize when the differences in your body from day to day. Because here's the thing, very often patients with interstitial lung disease or COPD or pulmonary hypertension will be breathless every day.
Yeah.
To varying degrees, and how much is it limiting? So being able to identify what are the activities that it is limiting, and learning to identify the maladaptive responses, learning to block the thought cycles which are perpetuating cycles of breathlessness as well. So all of this is what one can do. The second very useful thing is a fan. Just a handheld fan, simple one with a battery operated one, like just about 15, just about between 1 to 1.5 feet away from your face. Let it blow straight over your nose and mouth. And that sends signals to your brain that I'm getting enough air, that automatically starts slowing down your breathing, which is going to help your breathlessness settle down. So use of all of these things, a handheld fan, the right breathing techniques, looking at your thought and say that sometimes just developing a simple mantra for yourself, saying, I've been through this before and I'm going to be okay. Sometimes it is using something like an image that helps you. So it could be a poster that you put up in your bedroom wall or someplace, which is a beautiful, a seaside, a mountain that gives you peace. If you are a religious inclined person, and there's a guardian angel or a favorite god or goddess that you look up to, looking at that image will help you center yourself and then be able to control your breathing again and let that feeling pass. Sometimes it's about riding through that storm that breathlessness is taking you through. And you will use every tool possible, physical and emotional, in order to help you get through that storm. And you know that breathlessness is going to pass.
Right. Yeah.
It's just about getting knowledge back in your, this is okay.
Right. No, this has been interesting. So I think keeping a journal of your symptoms and how you are reacting to them, and then learning about these techniques and then incorporating them, and of course some of these beautiful tips that you just mentioned. You were saying something else, Doctor?
No, so I was just saying that, of course, in addition to this, if there's other symptoms going on, like you check your oxygen saturation, your blood pressure, if there's swelling in your legs and your weight has increased, then you might need adjustment of your medications. Yeah. And in some patients, as this advances further and further, they might need other medications. If anxiety or depression really becomes something which is limiting activity and then affecting your everyday life, then medication for that, or the use of certain medications like morphine for breathlessness do come into play as diseases advance. But I think that the non-pharmacological techniques are underutilized to a great degree. And I think rehab is also underutilized. So I sort of want to focus on that and say that, yes, that should be the first thing that we all train ourselves to.
Right. Okay. And so, I mean, when we are talking about symptoms, there are obviously some other common symptoms, and especially with pulmonary hypertension patients or even ILD patients who further progress into getting pulmonary hypertension, it's the medicine side effects, right? Which are a huge deal for us. Nausea, diarrhea, vomiting, the three big devils in our in our lives. Do you have any tips for us on managing those?
Tips in terms of the stomach symptoms are terrible because they also make you feel a little more breathless. When your stomach is squeezy, your breathing also goes off. Right?
Yeah.
These are, it's very hard to have a common, what's the right word I'm looking for? Like there's no silver bullet to these symptoms because it's very individual. Each of us as individuals react differently to different foods and different medications. And while all of the medications tend to have these as common side effects, what soothes that nausea, what soothes that diarrhea, what soothes the vomiting is different for each person. So some people's tummies are soothed by certain foods and certain beverages, and others find those exacerbating. So one is awareness of what suits you and what's not. And you mentioned a very important thing, which is keeping a journal. So if one knows that there are patterns, then one can learn to avoid whichever exacerbates it. Following the diet for a patient with ILD, PH, fluid overload tends to be very challenging and difficult, especially in the summer months when you have to restrict fluid and it's really hot outside. Yeah. Keeping up with the amount of protein that you need. Sometimes the taste isn't right. Sometimes you're having to avoid certain foods while the rest of your family is enjoying it. It's hard. So in order to kind of make sure that we minimize symptoms, you try and follow your diet as well as possible, at least 85% of the time, and you could probably cheat 10 to 15% of the time. As long as you're monitoring yourself well, you will be able to course correct by adjusting your medications. Smaller, more frequent meals throughout. I like to suggest that maybe keep 2 meals as focused on your well-being in terms of what are the nutrients that you need to get in, and then one out of those small meals could be just a little taste indulgence for yourself, right? It's not easy, especially when you have patients who are children.
Yeah.
Yes. It's really hard to not give in, to eat things that all your other friends around you might be eating or your family is enjoying. So I do appreciate the kind of restraint that it takes in order to do that. But these are a few tips that help. finding what medication works for you, finding the spacing and the timing of meals that works for you. Also timing your activities so that it doesn't stress you out. And sometimes that might mean that if you need to be outside, if you need to be traveling, then you might adjust the timing of your medication for some people you can, and for certain medications you can't. So it's really about being open to being honest with people, telling them that this is my issue. So can you rearrange my meeting in a way that I know that I will be able to be my full self? This is how our disease ends up interfering with our professional life and our personal life too. And it's not an easy one to manage that, but sometimes it's about acceptance and also being able to say that this is my condition and I can fully perform these duties as long as you give me the leeway in order to be able to work around my medication and my symptoms.
Right. Okay. Okay. Doctor, I think I know all my friends in the community, ILD and PH, we all suffer from some form of insomnia at some point through our diagnosis. Sleeplessness, restlessness, it could be because of O2 drops, it could be because of anxiety because of the O2 drops, or anxiety is about our futures. How do you help with this aspect?
So sleep is big in terms of as a problematic symptom, and also in terms of how it impacts the next day and your ability to exercise or your experience of fatigue the next day. So it again is one of those vicious cycles that one gets into. The first part of it is really to understand how to set it's called sleep hygiene in the world of sleep medicine, but how to set a routine which is conducive to getting good quality of sleep. Now, the number of hours will vary from person to person, but if you have good quality sleep, then that should make you feel that you are well rested when you wake up. Simple, again, non-pharmacological means that I would want to stress on first is making sure you have your sleep hygiene right, which is that, not having caffeine in the latter half of the day, making sure that you have some gentle form of exercise, say 3-4 hours before your bedtime. That will help. Making sure that you have your meal at least an hour and a half to 2 hours before your bedtime, your last meal. Having a lighter dinner, not too heavy a dinner. Also, in terms of making sure that your bedroom is a place which is only meant for sleep.
That's very difficult for us. Most of us work from our beds.
Exactly. So what I want to shift here is that it's in terms of position, right? So whether if you can do it, I know it's a luxury, it's not available, it may not be possible for everyone, but even if you can have something like a reclining chair and say that when I'm not sleepy, I'm sitting and reading and doing my work out of there, but when I lie down in bed, this is to go to sleep. So the bed is a place to sleep. Otherwise, what ends up happening is we are training our minds to be active while we are in bed.
Yes.
So being in bed doesn't automatically lead me to think, oh, I'm supposed to fall asleep in 5-10 minutes now, or even 15 minutes. So it's like I could be awake for hours in bed. So if you are not sleepy, move to a recliner chair or something like that, which allows you to feel restful, but is not the same as lying down flat in bed for sleep. So trying to keep devices away. The light from any screen, it's just like you were getting sunlight. So our brains were not really meant to be in this 24/7 light that we are receiving in the modern world. So try and avoid any screens, any bright screens for an hour and a half, 2 hours before your bedtime. Maybe move to a book or music or something like that instead. And then the next thing that comes up is certain mindfulness-based practices, right? So guided muscle relaxation, progressive muscle relaxation, and guided meditation. These are found to be useful for helping you in terms of sleep. Now, some of these things, even if it doesn't help you with sleep, will help you with getting more rested.
Right.
So that would really help. And if it is that despite all of this, you're not getting a good night's sleep, or the quality of sleep is leaving you unrefreshed the next morning, sometimes, of course, patients with any kind of, there could be an overlay of obstructive sleep apnea or nighttime low oxygen. So getting a sleep study done to see if you need oxygen at night is also important. If one needs a CPAP machine, then getting that on is important. And if none of those, then the use of certain medications to help with sleep is also perfectly fine, right? If it's about anxiety and racing thoughts, journaling again is a very good way of helping you to process the day's events and the racing thoughts. And then, so maybe journal for 5 minutes before the events of the day, so you're able to put that day aside and then do your progressive muscle relaxation and guided meditation, or listen to your favorite music. And then even if it's not sleep, your body will go into a more restful state.
Okay, all right. The psychological aspect of a diagnosis and the psychological aspect of dealing with the chronic condition in general. Do you recommend counseling at the very beginning of this journey, right after diagnosis? And would you also recommend family counseling?
Well, I think counseling in terms of when you, counseling is one of those things with a clinical psychologist that comes in when it starts affecting your life in a way that the big shifts are happening and you're experiencing big emotions, right? So it's hard to make a recommendation that at the time of diagnosis is when you do that. But if you think it's impacting your life, your responses, your relationships, then most definitely. If there are big shifts that are happening in certain aspects of your life and you're experiencing things like this feeling of anxiety, if you're feeling panic, if you're feeling anger, if you're feeling tearful and frustrated, if you're feeling that your relationships are getting frayed, any of those things, that might be when you might want to seek counseling. Now, most definitely family counseling if it is causing tensions in relationships. And chronic diseases can cause tensions in relationships because there's certain equations that change. There are certain parts of who does what that changes. There are certain dreams that one had as a unit together which shift. So there's a lot of changes that happen, not just for a patient, but also for members of the family. So that's probably when it comes in. Now, the counseling, again, could take two forms. One is just having a more longer, honest conversation with your primary treating doctor, your cardiologist, your pulmonologist, and having them explain to family members what to expect for you in your life and the kind of support you would need. The more complex part of it is if there's emotions involved and unresolved issues that one needs to think through. Because there's a lot that can be achieved with a clinical psychologist who's able to guide you through the way your life is changing with a diagnosis like PH or ILD. I've seen families go through things like a parent and a child where maybe a parent has ILD and the child takes on the role of caregiver, and everything is about oxygen is okay, medicines are given, nebulization is done. And that's the only conversation that you're having from morning to night. And where did the parent-child relationship go? Where did the having fun over a game of carom or playing cards or watching a TV serial or watching a cricket match go? So building that back into the routine as well to preserve what was the first relationship of care before it became caregiving.
Right.
So if one sees that it's not really, that it's becoming harder to hold it together, then a few sessions with a psychologist, a family counselor can help a lot, because it's a long period of time that one has to walk the journey together.
Right. Doctor, in the case of pulmonary hypertension, especially when younger people are diagnosed with it, I think the whole family is in denial. So we've often, thought that family counseling at the time of diagnosis itself would be much more helpful
I totally agree with you, Shalaka, especially with younger women, and
Yes.
especially with severe PH in younger women. As a society, it can be really hard to be faced with that diagnosis, and especially to understand the impact that it might have on certain aspects like, intimacy and, bearing children and all of those aspects, right? So it's important for the entire family to understand, for partners to understand what is possible and what is not possible. And I think the more honest conversations that one has, one realizes that there are options available, whether it is in order to have a fulfilling physical relationship and to maintain, intimacy, as well as in terms of what is safe and what is not in terms of childbearing, and what kind of options are there. If you have a nurturing instinct within you to be a parent, then exploring other options other than having babies of one's own, right? So there's a lot of issues that one has to discuss, and it's all about safety. Each patient is different, each family unit is different. And we would rather have these conversations in such situations sooner, rather than land up with complications in unplanned pregnancies.
Right, right. Doctor, what about cognition, attention, memory loss? Because these aspects, when they get worse, they impact every aspect of our lives. So is it real? Does it happen, or are we imagining those things?
I don't think you're imagining anything. All symptoms that patients say are happening are true and real. And it's only our understanding of the how and why which has expanded over time. So we know that chronic pain over time literally changes the way our brains are wired, and our future responsive. Similarly, chronic breathlessness does that to us as well in many ways. And it is a kind of trauma that you are experiencing. So now, one of the things that I want to, whenever you experience these insults, micro or macro, on your way of thinking and the physical symptoms themselves, it can cause certain effects in terms of your cognitive function and things like that. How does one deal with it and cope with it is by, again, working out with, I think a psychologist can help a lot over here as well. I think another thing that happens is going with certain types of therapies also helps in maintaining functions, right? Learning how to organize our days and ways in which we manage to not drop important balls that we know that are crucial either to a professional or personal problems that we want to solve in a day. So we all learn ways and tricks of helping us to, okay, you might drop a few balls because of cognitive loss, but you're not going to drop any major fragile glass balls in that.
But there is a cognitive loss, right? And there are memory issues as well. I think a lot of us are unable to accept this reality because our doctors sometimes deny it. Hey, no, that's not so. They probably are just trying to, help us believe in more positive outcomes, but this is actually happening. And as in the patient community, we acknowledge it to each other and we joke about it because we don't remember so many things.
I think this is a very important learning for us as doctors, which is to treat your concerns as real concerns. And it may not be something that's measurable by us on a scan or a test, which means it isn't something I need to treat with a medication, but it doesn't mean it does not exist.
Yes.
Right? This isn't something I can prescribe a medication for, but it is something that you would figure out an organizing fix in the day for you.
Right. I mean, if I accept it, if my doctor agrees with me, and then I can probably deal with it better with my family members, with my friends, right? Absolutely. Because I'm accused of, I mean, not me personally, but I'm accused of forgetting birthdays or forgetting important milestones, forgetting small things here and there, forgetting to call someone. Yeah. So if if that issue is accepted in general in the community, starting with the doctors, it'd be easier for us patients to deal with it.
Point well taken, Shalaka. I think as doctors, just because you have a certain set of symptoms which conforms to a disease, and if new symptoms come in saying, oh, that's not really true. No, anything that you report to me and which matters to you in your life is real and true. And again, when we make measurements and assessments of these symptoms, it may be that I don't find something which needs some kind of a clinical fix, but the problem is real to you, and it, one has to try and find ways around it to help one cope with it. I think most definitely. There is one aspect that I was speaking to you about, how chronic illnesses changes us and transforms us. So just like trauma changes our brain, healing can also help. So when you adopt practices which help you cope, even that will have a positive effect going forward, right? So just building up systems that help you. But yes, the first part of it is accepting that, yes, we might need a little more.
Right. Okay. Doctor, so there is another aspect to this, which is both ILDs and pulmonary hypertension in general are invisible conditions. So we don't necessarily look sick. And yet we have a scleroderma friends for whom it is quite a visible disease. So there are disadvantages to something being invisible. There are disadvantages to something being clearly visible. And when it comes to appearance, another aspect is of using tools and aids such as wheelchairs or walkers, or sometimes just a cane if absolutely needed, or even a mask, a nasal cannula or a mask. And so many people in my community, unfortunately, refuse to wear or use these things in the public because they do not want to appear to be sick. I mean, we are not sick, but appear to have to deal with something. So how do you deal with patients like us on these aspects?
It's such a complex question, Shalaka, because, far be it from me to say that since I cannot fully comprehend the experience myself, all I can make is suggestions about what I, as a clinician, see as the benefits of using the aids. So one of the, what I like to explore at this point is, why is it that you do not want to use it? Why is it that you do not want to use a nasal cannula or a face mask? Why is it that you do not want to have the cane? And what are you losing out because you are not willing to use oxygen in public, or use a cane or a walker or a wheelchair in public? What are you missing out on? So if I look at what are you missing out on, and then say that, let's work at this way of thinking then, that I don't want to appear weak, I do not want to appear dependent, I do not want to, but is the desire to participate in a social event, in a gathering, greater than this desire to not be seen as, right? That's what we try to get to, and say that these are not signs of disability, they are a boost to your greater ability despite having a chronic medical condition. So your oxygen is not limiting you, your oxygen is actually allowing you to do more. The cane is allowing you to do more safely. And that safety is important. So a cane allows you to do more, a wheelchair allows you to do more. And this can take time to work at acceptance and say that, yes, this is something. And then you start to learn to let go of that feeling of, so it's a lot to do with your own identity and the story you tell yourself about, this is who I am, right? So to learn to change that story and accept the new story and say that, yes, this is who I am. I'm somebody who goes out with oxygen and still does all these amazing things, or goes out and works towards these things that I am interested in.
Right. Doctor, let's talk about professional disappointments that arise out of a chronic illness diagnosis such as these. Job loss, monetary loss, financial losses, or financial strain, both on the caregivers as well as the patients. Pulmonary hypertension is one of the most expensive diseases to treat. ILD patients are okay. I mean, reasonable cost initially, but when the pH comes in, it raises the cost of therapy. Oxygen concentrators are not cheap. And progressively, I mean, the financial strain gets worse. Lung transplants are exorbitant. How do we manage all this?
You know, it is so challenging, starting from what you said about, you know, professional loss and the financial strain onwards. And I would say that it's not just the patients, but sometimes it's for the extended family as well that applies. I know of patients who've had to give up more active careers and choose roles which allow them to work with their medication, oxygen, and limited mobilities based on that. Now, I think one of the important issues here is that as a country, we haven't yet defined disability due to things other than loss of a sense organ or a limb or neurological illnesses. Yeah. So moving on to respiratory and cardiac conditions, which are life limiting and therefore allows for a greater, you know, so this is a public health advocacy piece that maybe as a community that one needs to work towards.
We're working on that as well. Yeah.
As a patient community, as well as professional bodies, this is what we can work towards. As doctors, what we try to do is to appeal to the better part of employers to say that, you know, here's a person, these are the few physical limitations that they may have, and as much as possible, if they can, make accommodations in terms of work hours or, you know, office arrangements and things like that, can that be accommodated? That being said, it still is a huge mental adjustment for patients, because there's certain things that you might have set as milestones in your life that at this point in my life, I'm going to have done this, at this point, I'm going to have done this. So it needs a recalibration, right? We also now live in a more, you know, connected world. So earlier we used to have a lot more problems with young students when they're diagnosed with pulmonary hypertension, but not being able to go to college and make up their credits. And of course, now post-COVID, it's been amazing in some ways, because I have some patients who are able to access recorded lectures which their college professors had done during the COVID years. And then they're able to, you know, cover their portions with recorded lectures and then just go in for limited times for, you know, one-to-one interactions with their professors. So the world is moving towards making things easier for people to achieve their academic or professional goals in some ways, but I don't think it's fully there. I mean, it's a long way to go yet. Again, counselors do help with acceptance of these parts of it. When it comes to the financial part, again, you know, as professional bodies and groups, we do try our best to keep bargaining for costs of medications to be brought down and for more medications to enter India. That's been a challenge. It's, I think you're probably aware of it in terms of how many different groups of cardiologists, pulmonologists keep re-engaging in talks with pharmaceutical companies about drugs reaching India and being at a manageable cost for our patients here as well. Yeah. As you mentioned, with ILD, some of those drugs now are more affordable. Transplants still remain expensive, but the costs are going down. Again, another part of it is having certain state schemes coming in for which will encourage and allow more transplants to happen over time. But yes, the financial strain is huge. And there's no easy answers out of it.
Maybe we don't have the money to access palliative care services.
So here's the thing, that palliative care is actually not as expensive as of the medications and things are. It's usually the medications that we use in palliative care are the simplest of medications, and none of them are expensive. There are certain interventions which are done, which are really the cardiac interventions done for PH, which are considered palliative because they help relieve symptoms as well as decrease pressures, right? So like atrial septotomies, things like that. Right. But in terms of medication-wise, it's not expensive. The main problem with palliative medicine in India right now is that the number of palliative medicine practitioners are few. So access to palliative medicine specialists is difficult. Again, telehealth is now helping us to reach more, to expand the reach for more patients. And the more and more hospitals are recognizing the need for that. And the field is growing. So it's still a young field. It's only been, there's been a postgrad degree in palliative medicine only since about 2012 or so. So it's a
Okay.
and palliative medicine has been around in India since 1985, but we now have every year graduating batches of palliative medicine specialists. So I do think that there will be more palliative medicine trained nurses, palliative medicine trained doctors.
How many centers do you think there are in India, doctor? How many centers, palliative care centers or palliative care doctors in India?
Oh,
will there be thousands now?
There is yes. So now there is Pallium India is an organization that's based out of Kerala, and there's the Indian Association of Palliative Care. And I believe that both these websites maintain a register of all the places where you have palliative medicine practitioners, as well as access to medications.
Okay. Doctor, two important aspects that we need to cover before we open for Q&A is, let's talk about caregivers first. The burden on caregiving, the financial, mental, emotional burden on caregiving. What do you want to say to the caregivers here who've joined us today?
I think, firstly, I acknowledge the great role of caregivers in any patient's journey when there's a chronic illness that goes on for several years and shifts your life completely, right? Because it is impossible to walk that journey alone. Earlier we were talking about how this community of PH India provides the support, but there's a day-to-day support that the caregivers give, and they sometimes do go through fatigue and exhaustion and burnout. Very often they go through, their entire focus is on the person with the chronic illness, and therefore they ignore their own health. So very often they are not taking care of their annual health checkups. They're not taking their medications on time. And that classic cliched line that you hear in anything in an airline is like, first put on your oxygen mask and then help another person put on their oxygen mask, applies to caregiving too. Caregiving becomes a full-time exercise in and of itself. So it's important that in your routine, you build in the taking care of your own health in terms of your nutrition, medication, exercise, and sleep as well. And recognize that you'll go through ups and downs, and it's okay, and it's even for patients, it's important to understand that there will be times when caregivers are frustrated and mildly resentful, and it's okay. I think if you look at any kind of a marriage or a partnership, you will go through those ups and downs even without any chronic illness. It just gets amplified when there is chronic illness as well to deal with it. So it's important to find ways at least once a week to connect in the relationship of care, not just caregiving. And that, I think whenever I've had families realize that that's what's happening to them. Usually I can watch it happen over 3 to 6 months of, visits to the clinic, that, someone's just completely becoming about medication, this, routine, this and that. I'm like, when was the last time you had fun together? Just as a family, right? So it's important to start building memories by doing activities which underline and underpin that there is a relationship of love which is there before there's a relationship of care.
Okay. And doctor, end of life.
And I also want to say one more thing over here. I'm sorry.
Sure. Yeah, please.
Is that sometimes it's necessary to get in an external caregiver. So to recognize when it is taking a toll on your own health and bring in the help and ask for help as well. And to take breaks. Sometimes one needs a little respect, right? So making sure that sometimes a little distance is needed, and all of this is perfectly okay. Caregivers sometimes carry a lot of guilt, and patients carry a lot of guilt as well about, oh, my son is having to do all this because of me. Oh, my wife is having to do all this because of me. Oh, my husband is having to do all this because of me. They're doing it willingly. And yes, it is hard on them. But if we keep saying that, oh, this is because of me, I am a burden, it again makes it burdensome to them to even listen to that. So maybe one of the ways of reframing that is, thank you so much for doing this for me. So, and just changing it from one of burden, negativity to gratitude and blessings instead.
Right. So it is something that we as patients need to learn in terms of how we treat our caregivers.
To accept and receive help and say,
yes,
thank you and God bless you for it. Each time, oh my God, your life is going to be so full of blessings because of this every day. It's like I'm adding to your good karma continuously.
Yes, yes. Doctor, let's talk about death and end of life care. So what happens when we run out of options? We run out of pharmacological options, we run out of money, and Doctor, are you there? Yeah. Did you hear my question, Doctor?
I did.
Yeah. So when we run out of options, pharmacological, as well as we run out of money, we run out of, no recourse to lung transplant either for some or the other reason. How do we manage that? How do we manage a prognosis that is, that is about to end? What can caregivers do? What can patients do?
This is part of a much larger. So one of the, this is a challenge for all of us as a society, that we are a death denying society. Where all of us are born, all of us are going to die, and we never want to talk about death at all. But you realize that once you start talking about it, just as it happens to everybody, right? It liberates you, because there's a lot of understanding about values and beliefs that comes out by having these conversations. So if I were to think about it, while I am healthy, that would be the best time, right? While I am nowhere close to death, that would be the best time. So I would think about it now and say, what in my mind is a good dignified death? A good life should also include a good death. And then most people will say that the best kind of death is ki one jhatka, one shot, and you're gone. Well, that happens to only 7% of people in the entire world. Another 16% may have a life-limiting diagnosis where very rapidly, within 6 months to 9 months or 1 year, their health declines and then they go. The rest, which is like 76% of people or 77% of people, know that they have an illness and they are progressing gradually towards an end, and they don't want to think about it. Now, if you and I are going for a one-day trip, we plan what to pack, what to take, what I want to eat, who I want with me, who should drive the car, what should be the music playing in that.
Yeah.
And here, this is the big journey, and we haven't planned about it. Right? So just thinking about it, what in my mind is that? And what is the support I would need for that? So then it becomes much easier. Saying, if I think that, okay, jhatka se death is not going to happen, then where should it be? So I would want to be in my house, in my bed, or I want to go to this one peaceful place and be in this place before I die, or these are the things that I want settled before that happens. So that's sort of one of the things that's important. Another thing that becomes important is if we have decided, or if we know that we, that lung transplant, heart, or any kind of transplant is not an option here, then making sure that you have access to a palliative medicine doctor or to medications to help you with the breathlessness. What do we fear most? We say many people fear death. It's not so much death we fear as suffering just before death.
Right.
So if we express to our healthcare team that I really don't want to suffer, make sure you give me medicine so that even like if I am getting more breathless, you make sure that I'm not feeling breathless. You make sure I don't experience pain. This is 2023. We can help do that for most people. Right? So that would be something that you ask for.
Especially ILD patients, I have noticed that, usually most of them die on ventilators because
that's really hard, because if you're not, especially, that's something that one needs, allows us to make a living will, where patients can decide and have full, authority over how end of their life should be. So it's important to have the conversation as doctors. If our patients have had the conversation, it is our responsibility to initiate that conversation with our patients if their health is declining. But if not, it's perfectly fine for a patient to initiate that conversation as well. And it's always good for a family member to also be a part of that conversation. One of the things that happens with chronic illness and with caregivers is that even if times patients want to talk about it, if the next time I'm really sick and I might die, maybe they don't talk about such things, nothing is going to happen to you. No, allow the person to speak more at that time. What do you want? Yes. Okay. Do you want to speak to so-and-so? There are times when we have unfinished conversations and unfinished business. We must honor that. So if anyone who has a chronic illness says, I might and I want to do this before I die, we shouldn't stop them from speaking about things that they want done or the way they want things done. So the more we know about, the more we can honor their wishes and make sure that dignity and comfort is taken care of at the end of life. I definitely think the ICU is not the right place for most people to. Even if you are in a hospital, that's fine, because sometimes the nursing needs are harder for the family to manage at home, and a hospice is not available in every city. Hospitals can be geared up to take care of end of life in a very dignified and supportive way.
I think a challenge that we face when we want to talk about death, especially from family members, is that that's a negative subject. Let's not be negative about it. Let's be positive about this condition, and only positive things will come about. But we know for a fact that science and other patients' experiences have told us that this is how the journey is going to be, and it's going to end up in an early death, a possible early death. And we do face that. I mean, from patients as well as patients' families, like, let's not talk about it. That topic is completely shunned. So let's not even plan about it. Let's not even express our, desires about how we want it to happen. Doctor, what about euthanasia? I mean, so all of us at some point have thought about it. Is it legal in India?
No, it's not legal in India. So euthanasia in this common understanding of the word is mercy killing, is what it used to be called, which is a deliberate action which accelerates or brings about the death of a person, right? It's administering a medication which will accelerate the process towards death. And that is not legal in India. What is legal in India is a patient can say, I do not want this treatment, I do not want this treatment, but I want to be kept comfortable, right? So I can administer medications which are from the opioid family or from the sedative family, so that you don't experience breathlessness or pain. That may lead to a drop in blood pressure or oxygen saturation, but my intention is not to hasten death in any way. My intention is only to bring comfort to somebody who's already at the end of their life and death is imminent, right? Okay. So that is legal and can be done. The process for it in how one lays that one might say that is done, right? And it's a well thought out decision by a patient when they are not in a critical condition, when they are in an emotionally stable situation, when they are not facing clinical depression. So when patients tell us, when they have perfect understanding of what's going on with their disease and what's happening, and this is an expressed wish that I do not want to be in the ICU, I want to be with my family. You are with your family, and the disease is progressing, and your saturation is low, blood pressures are dipping, but you are experiencing some breathlessness. It is perfectly okay for a doctor to give you medication only as much as is needed to relieve the discomfort.
Right. Okay.
And it's called allowing natural death to occur. It's not euthanasia.
Okay, got it. Doctor, would you mind if you take Q&A from the audience for 5 minutes before we close?
Absolutely.
Okay, does anyone have questions here for Doctor? I think there was one question about, someone was asking about the Kerala center that you mentioned. Was it Palliative India?
It's Palliative India, which on its website has a directory of palliative care centers, and I think the Indian Association of Palliative Care, which is the professional body of all palliative medicine professionals in India. Both of these have, you'll be able to find a map with the directory, and
yeah, they are on Twitter. I have seen them, and I will share with the community. I should also mention that Dr. Rajani Surendar Bhat is also on Twitter. Please follow her there. Doctor, are you on any other social media? I mean, professionally? Okay, so we follow you on Twitter then. Okay. There's a message from Scleroderma India saying managing ILD with scleroderma is a double whammy. We really don't see doctors mentioning palliative care here. How can it benefit us?
So again, the kind of symptoms that patients with scleroderma face are so many, right? I mean, there's breathlessness if there is ILD associated, all the symptoms of ILD and pulmonary hypertension that patients with scleroderma can experience, but there's also GI symptoms, there's, you know, the esophageal symptoms that one has, there's the skin symptoms that one experiences, there might be pain. So what happens with palliative medicine is we take a more comprehensive approach to all the symptoms, as well as any side effects related with medications. Yeah, so the idea with palliative medicine, really the principle is that what we address is total pain, and total pain is physical, psychosocial, spiritual, financial, all of that. Each of these aspects impacts our experience of suffering because of a disease. There are, you know, questions about why did this happen to me, and losing faith, and, you know, ebbs and flows that you will have with positive emotions, neutral emotions, negative emotions coming through the course of a long disease. And that's where palliative medicine helps, because we don't just look at purely the physical component, but as we also look at the psychological impact of a disease, the spiritual impact of a disease, how does it affect your personhood? And of course, the social aspect in terms of finances and relationships as well.
Doctor, maybe it's something, you know, I would request you to take back to the medical community, is that rheumatologists, forget pulmonologists and cardiologists, rheumatologists also do not talk about palliative care, especially when they know that some of their patients with lupus scleroderma are, you know, getting ILDs, and, you know, they should be starting to talk about it. Lung transplants is also not being spoken about, but this needs to be talked about in a country like India, where, you know, everything else is expensive, and at least this addresses some of the core issues of the patients.
I agree with you, Shalaka, and actually I think there's been a greater push over the last 4 or 5 years to make sure that every subspecialty has a palliative medicine approach for patients with progressive disease.
Yeah, in fact, you know, a lot of times we are told cancer to nahi hai na, to theek hai, which is we really don't know how to take something like that, because, you know, it's equally debilitating. It may not be as, you know, as fast and progressive as cancer is. Some of the cancers are quicker progressively, but yeah, I mean, we have to deal with that. Okay, so
I think you're so right, Shalaka, because if for cancer we have better prognostic indicators, and with many of the diseases that come with connective tissue diseases that are ILDs and PH, there's a lot of uncertainty, and that's also one of the big reasons why it's hard for us to predict what might happen, and that's why certain delays in referral to palliative medicine happen, because we don't yet have accurate indicators that tell us, oh, this might suddenly deteriorate. So that's one of the big reasons, but we're hoping that attitude changes and early referrals start happening.
Okay. Doctor, there's a question. We are ill for so long, people exhaust their empathy for us. I'm facing the same, especially at my workplace. How do I deal with it? Like, how many leaves will you take? How do we keep accommodating you? Why should we keep accommodating you? We are a business at the end of the day. Doctor,
I hear you. You know, it's really hard. I said I hear you, and, you know, I am so sorry that this is a really harsh reality of loss of empathy, and just not being able to connect with what might, as Shalaka mentioned earlier, invisible illness, right? I really wish that, as we were speaking about it earlier, that, we're able to bring about some change in workplace laws, which counts for these kind of illnesses and allows for that more. There are some states also which are trying to make certain efforts to address the kind of distress that comes with it, So there's a lot of work yet to be done in that area. For example, in Kerala, your electricity bill is waived off if you're on an oxygen concentrator.
Okay.
It's little ways.
Yes.
Yeah,
that's a huge deal. Yeah.
Little
Okay.
ways to support. Yeah.
Yes. There's another question on being judged for using aids, medical aids, such as wheelchairs or other things.
That I think that's an ailment in our society. And I think the answer to that is really going to be with education and greater public awareness. We as a society do not build common spaces which are accommodative. You won't find ramps, you won't find wheelchair friendly access in many places. The roads are really, difficult to navigate. More inclusive schools,
Yeah.
And I think that's where the change is going to come, where right from an early age, we learn to accept that there will be people with different abilities and different challenges in every space that we inhabit.
Yeah.
That's what it's going to take to build a more inclusive society and a more empathetic and understanding one.
Meanwhile, we just have to be stronger individuals, I think.
Meanwhile, reach out to your community. Yes. Meanwhile, you raise your voice on days when you have the energy, and on other days you conserve energy.
No, I think creating awareness also has been helping. People have been, once you get aware, you are probably able to understand and therefore empathize, and that helps. Doctor, there's a question on palliative care for children. Is there such a thing?
There is.
Children with these conditions, especially congenital heart disease and pulmonary hypertension.
Definitely. So pediatric palliative medicine is a separate specialty. Usually these are specialists who are trained in pediatric, they're pediatricians who then specialize in pediatric palliative medicine. And definitely for children born with congenital heart diseases, neurological disorders, inborn errors of metabolism, it's a huge area, along with childhood cancers and things like that. So we have a few pediatric palliative medicine specialists in India. There are collaborations that are going on with universities abroad for training more people. I know that Nilofer Hospital in Hyderabad, and there's an organization called the Pain Relief and Palliative Care Research Society in Hyderabad. Dr. Gayatri Pallat works towards pediatric palliative medicine at Tata Memorial, Dr. Mary Ann McCudden. So there is a growing number of pediatric palliative medicine specialists across India, because here you need support for the patient as well as for the parents. To the journey.
Yeah, but it is something that should come from the pediatric cardiologist, right? He or she should be recommending this.
Absolutely. And yes, there is a growing number of pediatric palliative care specialists, and I really think that it would be, these are the things that one nowadays can reach out for online support as well, for teleconsultations as well. Okay. So that would be something.
So online consultation is a big thing now with palliative care in India?
Online consultations are happening across the board.
Okay.
The one thing where I think the palliative medicine as a specialty in private and corporate hospitals is yet to pick up more, because again, as I said, it's not a paying specialty and there's no big money in it. But there are many specialties like that, but it adds value to a patient's care. Okay. And it'll also help for growing this field if there is a greater demand from the patient community saying we would want
Doctor, we can't hear you.
I'm sorry, my signal was off for a
No,
while.
no, that's all right.
I'm back.
That's
I'm
all
sorry.
I think let's give her a moment.
Are you able to hear me now, Shalaka?
Now we can. Yes, yes, that's all right. Doctor, I know you've answered this question before, but I think this is one of the most important aspects of the session. Therefore, could you please repeat this? When should one opt for palliative medicine or care?
Whenever you have a significant deterioration in your medical condition, which is leading you to either have repeated hospitalizations, require more assistance in terms of not being able to do your daily activities because the burden of symptoms has gotten that much. The first time that somebody gets to a point where they require regular use of oxygen and is experiencing breathlessness to that extent at all times, those are the first inflection points that I think one should be seeking palliative medicine inputs. And then again, as needed, whenever there is an uptick in symptoms and that's disturbing your quality of life, right? If pain is not adequately controlled, if sleep is not possible at all, and your primary doctor, your cardiologist, pulmonologist has done whatever medication adjustment and you're still not getting relief, that's when you should be saying, this is complex symptoms and I need more now.
Okay. Doctor, two last questions. One is again about children, but this time about communicating about your condition to your children. How parents suffering from PH or ILDs, how should they communicate to the children? The children worry about it. There's obviously signs of anxiety. And these are, preteens, smaller than those, also teenagers. How do you think this communication should happen?
Very difficult and very important one. So in terms of understanding mortality, the way our brain develops is that until the age of about 6 or 7, we don't really understand what is death, right? It's an abstract concept that somebody's gone off to sleep. Are they coming back? Are they not? And children will often cope with distressing things that they witness around them, which might be that a parent is going to the hospital very often, is unwell, seeing any needles or oxygen or equipment around the parent. They might initially have concern, and then you might find them playing normally. So that's a coping mechanism that's perfectly normal in very little children. As they get older, beyond the age of 7, 8, 9, they start understanding the idea of mortality. There are ways of explaining to them simpler in a way that, okay, these are limitations in activities and you need to be careful around the person at home who is not well. And they start to understand that more at that age. In terms of explaining about end of life and death for children, preparing them for it, I definitely understand that they use play therapy, they use art therapy, right, to understand what the child's concerns are. Yes, because if we don't address the fact that the child is noticing and observing whatever is happening in the home, the child may start thinking and imagining things on their own. And very often, these may not be the right idea at all. Sometimes if they are completely left out of the picture, especially when they're a little older, they may carry guilt for a long period of time.
Yeah.
So it's important that we seek professional help if it's accessible. If not, think or try and find ways of eliciting what they are thinking and feeling. And play and art are good ways of accessing their inner thoughts and emotions.
So for older children, I mean, still children, but older children, communicating them about your condition is important, right? Or is hiding okay? Because we've seen patients who hide from their children as well. What do you recommend?
For the older children, it is always better to let them know, right? In everything, one has to balance how much of truth telling happens and how much of taking away hope happens. So it's about giving small bits of information at a time and also trying to help them find ways of coping with it in that way. Again, as I said, it's important because the more you keep from them, there's stuff that they will build up with stories of their own in their head, and these may sometimes be damaging to them in the future, right? Very often they will blame themselves for a parent's illness.
Yes, or that I did not do enough when I had the opportunity to do it. Yeah, yeah.
So it's
okay.
important in that way.
Okay, doctor, just one last question before we close. How much does it cost?
How much does it cost for a palliative medicine consult?
Yes.
Just as it costs for any physician anywhere. It's just a doctor's consult.
So do we have
and in terms
any
of
numbers?
medications,
You're breaking, doctor, so I couldn't hear the whole sentence.
It's very variable, right? I mean, a lot of palliative medicine that's done across different cities is in charitable hospitals, so it really doesn't cost much at all. In private hospitals, it would be the consultation fee that is standard in that city. So it would range, you know, from a Bangalore to a Bombay, from whatever, around 750 rupees to, I don't know, 1,000 something. It's just a consult, but one spends a lot more time. Now, in terms of medications, some medications, which are pain medications, may cost a little more, but most medications that we use in palliative medicine are not expensive. Morphine, for example, is not an inexpensive drug at all.
Right. Okay. I think, doctor, we should close here. We've actually taken a lot of your time. We've gone overboard with this, but thank you so much for agreeing to do this today with us. I think we've started a conversation on this subject, a long overdue conversation on this subject, especially in the pulmonary and respiratory communities, respiratory disease communities, because usually palliative care is seen only in the context of oncology. And we wanted to bring these conversations to us, to our communities too, to make us comfortable about talking about distress, about suffering, about pain, about death, and, you know, make these more everyday kind of conversations, talk about them more meaningfully with more dignity. I think all of us are going to learn about it. The whole ecosystem should evolve with all of us learning about it. Thank you so much, doctor, once again for this. We are just one last thing to everybody listening to me right now. We are going to upload this session on YouTube on Pulmonary Hypertension India, our account. You can please follow us on our social media accounts, Twitter, Facebook, and Instagram. And you can write to us or call us or scan the QR code, which is on my background and Prachita's background. Thank you, Dr. Rajani Surendar Bhat, again. We hope to have, you know, that your specialty progresses and becomes a primary approach or like a dual approach with pharmacological interventions for us, especially in ILDs and pulmonary hypertension. Thank you so much, and you everybody have a great evening.
Thank you so much, Shalaka, and thank you, Pulmonary Hypertension India. Thank you, Hema, for inviting me. And to this wonderful community, keep supporting each other. Happy that the conversation has begun.
Yes.
And many more to come. Thank you.
Thank you.
Shalaka,
yes.
Just before doctor leaves, hello doctor.
Yes,
just one last question. Can we do an online consult with you for palliative care?
We can do online consultations. It's just that I think in terms of prescription of certain medications, we are not able to do that online. And if that's the case, then we sometimes make arrangements for the family to see a local doctor who we can coordinate with. But making an assessment and all the non-pharmacological advice or many of the pharmacological things also can be done online.
So how do we, so we take an appointment with you through the Sparsh website, doctor? How do we reach you for a consult?
That's probably the best way. On the Sparsh website, you should be able to approach me.
Okay. All right. Thank you. Thank you. I think many of us will approach you now. Be ready for a barrage of consults on this subject. Thank you so much. All right, everyone. Good evening.
All right.
Bye.
Bye-bye. Ciao.
Bye.